Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over a Monday. This is called $1 Million Minute, so I'm kind of sharing what happened to help get to $1 million mark and beyond in the practice. So there were 18 appointments, so that means there was an hour and 20 minutes that were open. And the neat thing about this is I've always asked my staff to try to move people up or try to fit in people. So maybe because it's a Monday, there were more patients that wanted to come in, but we did fill all the slots in the day. I'll talk a little bit about, the ones that were added on first. One was added on. This is a patient that had posterior tibial tendinitis, and they had pain in that area after a really bad ankle sprain. And this was a physical therapy assistant, and I put an Uniboot, got an X-ray, and I'm going to see them back in a week to kind of see how they are doing. The other patient that was added on was a patient that had some anterior lateral ankle pain and some pain to the intermetatarsal area, approximately between the first and second metatarsals. Got an X-ray, got an ultrasound. I did a cortisone in both of those areas to help kind of reduce the pain for this guy. And it took me a long time. I look at his X-rays. I spent a lot of time with him. And I'm going to see him back in a week, see how he's doing. And then the other one that they added on was a fracture to the tip of the hallux. So I did a new patient visit, got the fracture code, and I think he's going to just feel just fine. And I did also a nail evulsion because there was blood underneath the nail, and there was no real deep laceration that needed to be sutured, but there was that fracture. And the other one that was added on was a patient. She came in, got an X-ray. She had concerns of it looks like a nail fungus, but she also had some left heel pain, and we set her up for 6 sessions of shockwave and got her a night splint as well. So this was a patient that we did. Okay, so those were the ones that were added on. I was kind of pleased about those add-ons, but I'll go through the regular ones now. First patient was a Lamisil booster, so this is a patient, I see them, and then I see them 3 months later, and I give them another round of Lamisil at a much lower dose for 6 months, and then back to the regular dose. I do that because I find many patients, if they're just on 3 months, the fungus doesn't completely cure. Next patient was a 55-year-old fifth met fracture. Put them in a walking boot that they actually had X-rays, and I'm going to see them back in 6 weeks to see how it's doing. Next patient was a 52-year-old patient with bunions bilaterally, got X-rays, and we talked about shoe recommendations. So I gave them my shoe buying guide, told them about Anya's reviews, and recommended Topos and Ultra shoes. Next patient was a fracture follow-up. This was a 6-week follow-up, doing fine. X-rays, no need for follow-up. Next patient was a 15-year-old, had ingrown toenail, so I did an IND on that. No follow-up for that IND. Next patient was a new patient that had injury to the great toenail. It was partially avulsed. I finished the job, so I did an office visit and a nail avulsion. No need for follow-up for that one. Next patient was a 54-year-old patient, had either a bursitis or a neuritis, kind of on the bottom of the foot. We did an X-ray, did an ultrasound, and I've told them just to kind of rest the foot and reduce the bending to see if it'll kind of calm down the bursa. If it doesn't get better, either cortisone injection or shockwave. Next was a new patient with some right ankle pain, but I got an X-ray, but really what she wanted was nail care, so they're going to be back in 3 months for nail care. Next patient was a 57-year-old that had Onifix that fell off. So we just did the office visit. So these are ones that I'm almost thinking about having my nail tech do. I don't do a lot of Onifix. I don't see the great straightening out of the nail when they're curved in, and when they fall off, it's no fun because they have to kind of waste a visit to see them. Okay. Next patient was EPAT number 5 into the ankle. This is a struggle. This patient has some kind of chronic ankle issues, and we've been trying EPAT for her. And I'm not sure it's going to totally work because she has arthritic changes, bone marrow edema, and everything else, kind of in the ankle joint region. Next patient's a 39-year-old patient. Got an X-ray, ultrasound, cortisone number 1 to the heel. And then I did also scan this patient for orthotics. I guess the reason that I did the cortisone for this patient and not shockwave is because on the ultrasound there was no real thickening in the area of the plantar fascia. So that makes me feel like a cortisone potentially could work, whereas in a lot of other ones I don't think it'll work. So that's why I usually do shockwave. So that was the morning. Now afternoon, the first patient was a 55-year-old female. I'm going to be planning on doing a bunion on her, and she is doing some pre-surgical shockwave. So recently at a shockwave conference, one of the things we talked about is there's increased skin improvement for healing, and I would assume bone healing as well if you're going to do focused shockwave. And so I am trying a few sessions of shockwave prior to her bunionectomy. Next patient was a 37-year-old. This patient had a previous ankle fusion and wanted orthotics, so this was orthotic number 2 for the day. So I did the orthotics for this patient. Next was a 58-year-old female. Came back in for plantar fasciitis after having a cortisone injection about a couple months ago. Helped her. She was going on a trip, that's why she wanted it, but now she realized there's a lot of thickness in the fascia. So we did EPAT number 1, and we're going to set her up for number 2 to 6, the other 6 sessions. One thing I found is ultrasound is really the thing that helps patients determine that they need shockwave. Okay, and I find that I try now to do the shockwave the first visit. So it's a lot easier many times for us just to schedule those, but I think patients appreciate it if you get it started, and then they'll just continue the program of the other ones. If you wait, a lot of times that can just delay everything. Next patient was a 39-year-old, got an x-ray ultrasound. This patient got an injection to the peroneals and had a kind of little effusions around the area of the peroneals in multiple locations. Post-injection, patient had absolutely no pain, so they were very pleased with that. Next was a patient for a psoriasis. This was a self-pay psoriasis that I gave a strong corticosteroid topically, betamethasone I think, and they got better, self-pay, so that was a level 3 visit for that patient. Next patient was a 27-year-old that had a really ugly nail due to an old fracture. Got x-rays, could see the old comminuted fracture that was healing, and since the nail was ugly, I just recommended waiting to see if it got any better. And then the last patient of the day was a 64-year-old that she's finishing the 6 sessions of shockwave on her second met head, kind of chronic metatarsalgia / neuritis in that area. She has already improved, and I'm going to see her back in 3 months because I think it's going to take a long time for her to get better. And then also over at lunchtime, I had a nice talk with another doctor. We're considering talking about doing like a kind of a mastermind with other like-minded business podiatry people. It was a nice talk, and I asked her she does a lot of orthotics, and I asked her how she does it. And she says she tends to use x-rays to show the calcaneal inclination angle, and this is something I typically don't do. So I think this is, if you guys do this on x-rays, I would love to know how you do it. But she talks about that and shows what the normal angle is, show how it's decreased, and then she also shows how that can affect the knee and the hip. And I think those are a few things that I don't typically talk about, is like the knee and the hip, and I think that's something that there could be a greater benefit for these patients in doing that. So those are the ideas for the day. For those that I think I told before, but I went to a recent shockwave conference. I put all those on podiatrypracticemastery.com underneath, or actually on top I put a shockwave, so you can get all the resources, everything that I've learned at all these courses, everything kind of in something called a Notion, which is basically a big workbook that explains everything in there that I found that's helpful. So if that helps you guys out, until next time.